Thank you very much, everybody, for coming today for this week's installment of our seminar series, Building Resilience in Food and Health Supply Chains. The goal of this series is to develop a multidisciplinary understanding of resilience by looking at supply chains of critical importance to everyday life. And this week's seminar focuses on the challenge of developing resilient health systems in Northern communities. It is my honor and pleasure to welcome Dr. Susan Chatwood, Associate Professor at the University of Alberta School of Public Health and a recipient of the McCalla Professorship, which recognizes outstanding contributions to integrative research and educational leadership. She also holds affiliations as Associate Professor in the Dalla Lana School of Public Health, YAY, and Institute for Health Policy Management and Evaluation here at the University of Toronto. Dr. Chatwood holds a BSc in Nursing from UBC, a master's degree in epidemiology from McGill, and a PhD in medical science from the University of Toronto. She was a scholar in the Fulbright Arctic Initiative, is past president of the Canadian Society for Circumpolar Health, and was founder and director of the Institute for Circumpolar Health Research in Yellowknife, Northwest Territories. She has spent most of her career in remote and northern communities working in clinical practice, public health, and research. Her research interests include circumpolar health system stewardship and performance, and the synthesis of knowledge that promotes broader connotations of health systems and wellness in the Arctic. So I'm delighted to welcome Dr. Chatwood to this School of Cities seminar series. The title of her presentation is Value Systems, Governance, and Systems Performance for Wellness in the Arctic.
Okay, thank you. Well, I think our 20 minutes is up. No, thank you for that thorough introduction. And yeah, great to see everyone and some familiar names and faces there. And yeah, so today I'm going to use a PowerPoint, and I apologize for those who are zoomed out, but to just kind of guide through the conversation. And I was, looking at the theme of this series and thinking about some of the work that I've been doing, looking at governance and sort of the determinants of health and how they impact wellness in communities, and then in turn, how our systems and policies impacting wellness. So I'm going to share with you some of the work that I've been doing in the circumpolar regions and give you a bit of overview on that, and then some approaches to measuring performance, how we're currently measuring health systems performance and how we might be measuring it. And I think I'd welcome everyone's thoughts coming from different sectors and who've looked at other sectors either in Canada or globally. Perhaps at the end to have a bit of a discussion around, what should we be measuring for wellness in communities and cities. So I'm just going to go to this, go here, and then have to go to my full screen here. Let's try this. Oh, that's a slideshow. I'm not seeing my bar at the bottom here, sorry, with the screen share, what I usually, oh, there we are. There, is everyone seeing that now?
Yes, we are.
Okay, and yes, and this is always an interesting experience, not being able to necessarily see people's facial expressions, or worse yet, see my own on Zoom. And but to please use the hand up, and Tracy or anyone, feel free to interrupt me with any questions or clarifications as we go. But I'll, aim to take about 20 to 30 minutes and leave some time for discussion. So again, the work that I've been involved in has been in circumpolar regions, and Tracy, of course, is very familiar with this geographic context, but it's the 8 Arctic states, so looking at the globe from the top down, and made up of the US, Alaska, Canada, the Northern Territories, Greenland, Iceland, Norway, Finland, Sweden, and Russia. And then the other look here is more or less demonstrating that cultural context through language, and this is sort of the breakdown of some of the language groups through the Arctic. And with these, there's often many kinship ties that you can see with the Chippewa, Dene, Slavey, Inuit, Sami regions, and then Inuit across as well. So there's many ways that we interconnect through the Arctic. And so looking at health systems in this context, there's many shared features that, makes one sort of stop and say, well, if we're going to be looking at Canada, where I live, why would we be comparing across the Arctic? And something that is shared in all of these nations and in many of these cultural regions are the shared experiences of geographic remoteness. So, and I'm sure this has come up at many when we're thinking about food security and transportation changes or chains. The same chains apply to transportation for healthcare or health services, and that remoteness can have impacts on solutions or challenges. Of course, seeing a big uptake in virtual health now and so on. In all the nations, there's shared experiences with health equities or health inequity, Indigenous values and health needs, and climate change and environmental effects on the health system. And so within these regions, it's important not only to look at the health system, or often we're talking about health outcomes or inequities, but to look at health system performance and what does performance mean in the Arctic. So this is and I think this sort of came from my background. Originally, many decades ago, I was a nurse in the Arctic and then sort of went more into epidemiology and population health measurement and looking at Arctic populations, and then got more into health policy and looking at system performance as a way to measure what is happening. And then the connection is then that those who make decisions or make policies use that information to inform better systems. And when I began looking at what health systems performance is, it quickly became evident in the literature that there isn't really a lot done that has an Arctic context. Usually it's national systems, like in Canada, CIHI, where data may be missing or variables may not be applicable. And likewise, in the Nordic countries, there's national measurement systems and the US. And I haven't studied Russia as much to know as much about the performance used there. But generally in Arctic regions, there's a common narrative that the performance isn't working or doesn't capture the full scope. So a few years back, we had a workshop to look at, well, what would health systems performance be in the Arctic and what do we need to be measuring? And this was held back in the good old days over at the Munk Center, and we had participation from Greenland, the Nordic countries, Alaska, Canada, and people working in government, deputy ministers of health, healthcare providers, and we had some Indigenous knowledge holders, and kind of used an observatory consensus process through the workshop to gather, what matters when we talk about health system performance in the Arctic. And some of the big themes that came out that I'm going to talk about today is the importance of articulating the values and context with respect to health and well-being, to build on Indigenous models of wellness, and look to multidisciplinary and cross-sector approaches. And I think, yeah, I'm interested today in also hearing from everybody about, coming from an interdisciplinary perspective, how does this model or how does this kind of work that I'm going to talk about, appear to you? But the one piece that really stood out was the values, and I'm going to talk a bit more about that. But before doing that, let's see what's happening here. Oh, there we are. Just wanted to talk a bit about sort of the traditional models for health system and what a health system is. And this is the World Health Organization, and on the left side of your screen are the system building blocks. So these are all the little Lego pieces that you need to put together when you then have a health system, and it all has to be working and coordinated. And then we have these goals that come out related to improved health. So sometimes we're measuring cancer rates or stages of cancer, or respiratory health, or different health indicators that are measured. And then sometimes equity, we're comparing the health outcomes, the responsiveness of the system. So this can be related to patient perspectives, and is the system doing what people expect it to? The social and financial risk protection. This is a big outcome, especially in countries where health services and healthcare is not universal, and the ability to access a full basket of services, and then improved efficiency of the system. And if we're sort of looking at this within the Canadian Health Act and what is the health system doing, this kind of model works quite nicely. But say when we have a group like ourselves in the room and we're wanting to talk about the health system, or after this workshop, and it was brought up at the workshop, like broader models to understand the health system. And one of the models, oh, this is the Kai-Hai, I think I'll skip past that. But one of the models that came up was a stewardship model for healthcare. And you can see here at the outputs are still the same, like looking at improved health, responsiveness, social and financial risk protection, and improved efficiency. But the difference in stewardship is firstly strongly being underpinned by the context and values for health, and having some sort of shared value system. And then also recognizing that you need to engage all sectors and advocate for better health. So whether it's agriculture or wildlife and lands and so on, and bringing that all together for health. In the case of this network, or this framework, it's still being looked at as sort of the health system, or the health, say your health department or Ministry of Health. But then how are you reaching out to these other areas and interconnecting? And so we began to sort of look at, how this kind of framework could be used to also incorporate some of the other areas that were raised at the workshop in relation to Indigenous values and moving forward. And it was actually sort of interesting for me because I'd always thought about health systems and whether as a care provider and how they worked for Indigenous communities or didn't work, but didn't really think about that piece of the values and Indigenous values and what actually does underlie the health system, and the context and the history, and that we hadn't really purposely pulled out this historical context and that impact that it has and the legacy that it's having. And what I did here, it's very small, but and it was built on some work out of the US, but did a timeline of all the major legislative and events for Indigenous people. And I only looked at US, Canada, Norway, and Finland, but started in the 1300s and identified activities or acts that happened. And it sort of broke down into these major phases. And you can see here related to, whoops, yikes. Now I hope I can get back. Thank you. Conquest, treaty making, assimilation, reorganization, termination, and then self-determination. And each of these is a flag for the nations, but you can see there's a similar historical flow. This is sort of one of my things that hasn't got published yet, every time I pull it out for a presentation, it's like, oh yeah, I have to put that together at some point. And so what you can see, and then, getting into reconciliation, but you can't sort of underestimate the impact that this legacy of assimilation has had on the values and the systems and how they operate. And I think, you're probably seeing that with food security in these other areas. But so if we're going to look at the health system, it's very important to pull these values out front. So I began looking through the literature for information on Indigenous values as they relate to health systems or governance. And it was quite interesting to find that there really wasn't anything there. That overall, we could see in the Canada and US, there was a lot of more literature related to the Canada Health Act and government control. And the values weren't really values, like they weren't human values. Like, well, as Canadians, we talk about access to health as a value, or so it's like access to the system, like universal care. It's not values related to sort of deeper reflections. And earlier here, I say sort of what a value being a subjective view of what's worthy or important, or sort of what unites us or brings us together around health and in this case, sort of health systems. And again, the Indigenous perspectives haven't really been identified in any of this. And that's sort of why I shared that detailed piece. And when you look at the history in Canada and many circumpolar nations, it's evident why that's happened. And we are in a big phase of reconciliation. And I think there are a lot more values emerging now and being captured. And so we did have there was another workshop held specifically with Indigenous knowledge holders and people involved in the, I guess, systems for health, like not only health systems, and did more of a consensus and sort of Indigenous methodology approach and identified these main values sort of emerged from this workshop. And in the search of the international literature, there were values identified in some national and international documents, like the Health 2020 developed by the EU and the Romanov report sort of talk about dignity, liberty, justice and fairness, respect, and non-discrimination. Interestingly, like none of those values really come up in any of our federal guiding documents in meaningful ways that they direct policy. And so going back to that stewardship framework, that's sort of a unique aspect of that. So, and just see how much I don't want to. So overall, looking at these values, it was important, and I don't want to read through all of this, but they give us an opportunity to take a broader look at sort of systems for health, and as opposed to health systems, and recognition of sort of this climate of reconciliation, and more of the holistic approaches, because the values speak to more holistic lens on wellness and community wellness and aspects that underpin that. So with some of the work going forward, then what I did was sort of a policy scan in some of the Arctic states and looked at, well, what policies might sort of align with some of these values, or how could this begin to get pieced together in a systems approach. And so this was the original stewardship framework piece that I'd showed you. And what I did was this top part is sort of that, and then dropping it down and then when one looks at it sort of through an Indigenous values lens, the broader vision that came out of that. So when we're with the health system, it's sort of the vision for health and the strategies and your policies within health. And this was more related to strategies to promote equity and sort of like realigning, how we're looking at this. And then, you begin to see policies emerging related to decolonizing strategies, multi-sector strategies and health in all policies approach. So, looking at, and again, I think this group's been doing some of that, like looking at how food security relates to health and these broader determinants of health. And then instead of just measuring these health system responsive pieces, when we're thinking about performance and wanting to do maybe annual reports or, begin to look at some timelines on outcome, to look at measurements around self-determination, culture and language, climate change adaptation, training and education, the capacity development piece, that sort of builds on some of the workforce pieces, and then sustainable communities. And probably many here have ideas on how that might be measured. So that's kind of the, look at our time, that where I'll sort of finish with the work. I do have the one slide I skipped over, I just realized was some work that we've done looking at what's currently measured in terms of health systems performance in Canada and gathered all the data from CIHI, Stats Canada, and sort of how, when we currently look at health systems performance, what's being measured and what we're seeing.
We have plenty of time, Susan, if you want to share that.
Okay, that was, okay, so I have to, yeah, so this was, it was the one I skipped over because I was afraid I was talking too much, but sort of looking at the health system framework and measurement and performance. And in Canada, CIHI is sort of the leading body looking at health systems performance. And this is the framework that they've been using, which, again, these outcomes are sort of the standard outcomes that you see in terms of system performance. In fact, Canada's, like, when you look at the international comparisons and OECD work and EU work, Canada's framework has sort of been one of the foundations that other nations have built from. So, and so they have, different buckets of data that they collect, and then recognizing this broader political context, cultural, economic, and demographic. In some of these elements, it's like huge question marks, like how are we actually connecting this and measuring? I mean, I think one area like I'm thinking a lot about is the cultural context and like, what does that mean when we're talking about system performance? And that was kind of some of the, what I was talking around today. So I'll just go over, trying to jump between things. So I did a paper with Greg Melchildon and Q Young, and what we did was look at the health system's performance, and it was sort of saying, well, what is available for Canada's North and for remote jurisdictions? And what we did was broke it down by the peer groups, which are used by StatsCan. And for those not familiar with those, it's essentially they use an analysis sort of looking at different socioeconomic factors and then group regions into Canada into different peer groups according to different, I guess, levels of determinants of health and the impacts in those communities. So you can see in Northern Quebec, some regions, and Ontario and BC, it's a peer group C. So that's a lower, if you will, impacts of determinants of health. As the letters go up, the impacts go higher. E and I, we combined Labrador with the northern zones of BC, Alberta, Northwest Territories, and Yukon. And then Nunavik, Quebec, Northern Quebec, Manitoba, Saskatchewan, and Nunavik have larger impacts. And so we pulled out some data. This was more StatsCan on determinants of health. And of course, it's not surprising then that we're seeing the darkened areas are where it's the performance is in the lowest quartile. So one would expect that we're seeing that here. And then here we're getting into some of the CHI measurements, health system inputs and characteristics. The reference for the paper, I can provide that after, but I just sort of wanted to show the general what's being done now in terms of measurement, ambulatory care sensitive conditions. So these are things like asthma and other respiratory conditions where you're seeing higher levels of admission to the hospital, which then demonstrates that your primary care system isn't working. So people aren't getting in to see a physician or a nurse in a timely way, and then their illness escalates to a point that it becomes a hospitalization. And so that's sort of used as a broad indicator. And we're seeing like some lower performance areas in some of these northern jurisdictions. And from a policy perspective, you probably want to look at that and say, well, what's happening in the primary care? Well, you know, our GPs are low and things like that. Like you can, you know, there's some pretty easy lines to draw, but then there's some stuff that becomes more complicated. You know, we're hearing a lot about the cultural competencies within the system and people's comfort levels and going to the health center in their community, and they may not do that. And then it's like a crisis and there's an admission. The rates of surgical readmissions. So ideally you have your surgery, you go home. That's not happening. Sometimes people are coming back more than they should. And then some of the health other outcomes related to hospitalizations for injury, for suicide, and there's different measures that. So this is sort of what we have right now in terms of performance measurement. And some of the work that I'm interested in continuing is sort of tying together these broader measures for health. I think if we just continue looking at only the health system with blinders on all the time, we're just going to keep sort of producing numbers without, you know, broadening it out and, you know, not only making these lines between, oh, well, there's, you know, high emissions for this and low human resource capacity, you know, but dig deeper and, you know, is there Indigenous capacity? Is there access to traditional knowledge holders? Like there's so many questions that I've heard in my work. So to continue sort of unpacking that. So I'll stop my screen share.
Wow, that's
a lot.
Well, that paper is such an important paper, and I want to open it up for general questions, but while we wait for folks to get their hand up or pop something in the chat, and I'll kind of keep an eye on that. I just wanted to take the speaker's opportunity, or the chair's opportunity, to ask what kind of response has been received to that paper from the federal level, Susan?
The one on the CHI and
yeah, the one demonstrating just how poorly the current system is performing for Northerners.
Yeah, I don't think there probably hasn't been, like, I think that, I mean, it was shared like at the territorial level with some of the decision makers, and I think some of that data, and then also this paper, I worked directly with the CEO within the Territorial Health Authority and sort of looking at some of the data and discussing it, sort of that, you know, had some direct conversations around the work as it was being done. And I think that's kind of the interesting thing is people are aware of the outcomes. They're aware of the system challenges and sort of this, and the questions sort of, you know, what is the next step? And I think sometimes the next step is beyond the health system. So it's sort of working with these sectors outside of health. And then, you know, at the same time, there are primary care reforms going on. So I think, you know, in part, they're probably like, okay, we can see there's some challenges with primary care, and trying to, at least in the Northwest Territories, unpack and address that. In Nunavut, yeah, there's more coming out about the cultural competency of the system. And so I think the conversations are emerging, and it's, yeah, having that capacity to be doing that um, in the North as well. And, you know, and recognizing where data is not being collected. CIHI has a working group for rural and remote regions, and there is representatives from, well, it's a Western one, so it has the Northern Territories, and then from Saskatchewan, maybe Manitoba across. And so that brings together decision makers, and CIHI is working on a rural and remote framework. And so I think there's some conversations. Indigenous governments are also looking at, like in Yukon, there's, well, as you know, like it's a provincial territorial jurisdiction, but then also Indigenous governments are taking on jurisdiction. And I think that's one, not speaking for all the Indigenous governments, but some are quite interested in looking at more of a value-based approach, which the chiefs in Alaska have used, and it's been created one of the best performing systems globally. The South Central Foundation is Indigenous run and very value-based oriented.
Okay. Are there any other questions for Dr. Chatwood?
I had a question. Thanks, Dr. Chatwood, for that.
Hi, Sophie.
I wanted to ask about what the response has been to the stewardship work, like the stewardship work, if the territorial government had responded to that piece.
In a word, no, but I think it's a really complex policy piece to unpack further. And I think some of it needs to be put more in plain language as well, some of the findings in terms of how this might be done, or to reflect, you know, more what people are doing already or have been working, where they have been working across sectors, or and maybe like COVID's providing an opportunity to sort of translate some of this, where there has been, you know, a very rapid movement in multi-sector collaborations, and there was the creation of a COVID response unit in the Northwest Territories, and probably that's another piece a student is working on now, a review of all the policies that Indigenous governments and regions have taken in COVID. And so that might be a way to kind of do that. Here's what we did for COVID, and well, how would this work, you know, with other conditions, even like diabetes, for example, would be a very good example of something that requires like an emergency and cross-sector approach to yeah, increase access to healthy food, or, you know, what's sort of one determinant, as using it as an example sort of with this group here. But yeah, so I mean, they're aware of the work I was doing, and the like the deputy ministers participated in the original performance piece, sort of looking at what is needed for performance. So the leadership is part of the group who's saying we want to look at this differently. But then you sort of get back into your silo within your jurisdiction of the Canada Health Act and what you're required to do. And I've actually ended up sort of looking into some of the legal research and law and what's happening there. And it's interesting, if you look at the sort of the boundaries of the Canada Health Act and Indigenous self-determination, it's really going to be some legal challenges, I think, that begin to shift some of these boundaries. because it hasn't been described yet or documented. So I guess, Sophie, I'm saying there too, like, if there's not a response, sometimes there's not even the boundaries there to respond and how to do that. And yeah, I think the Indigenous governments are taking some more creative and have a bit more of a blank slate to work with.
Yeah, that's so interesting. I'm looking forward to talking more about that with you. But thanks so much. This has been such a fascinating presentation.
Okay.
Thank you, Sophie. Laura Rosella.
Hi, thank you for that really, really great talk. I have more questions for myself than necessarily questions for you, but one thing I'm just grappling with across many of the talks actually that we've experienced is how we get away from the tendency to do performance management and measure things in the health system, which tells us about problems that we already know, when we know that in order to have performance measurement, like things that are actually going to change and improve the system, they are things outside the health system and the healthcare system. And it's been a real struggle, like I think a lot about public health system performance, to try and get buy-in to include some measures that are things that are outside the control of the health system. It's another silo that we've talking about. So I'm just wondering if you've experienced this yourself in your conversations about this idea of shifting what we measure to actually things that don't even have the word health in it, or even have a nearby to health, and they're actually quite upstream, and how we incorporate that into a formal performance management.
Yeah, and I think I've thought about that a lot as well, because we're sort of in this place where there's a lot of like, and even like CIHR, for example, and the initiatives, and it's like, okay, you got to be like working closely with decision makers and make sure the work is relevant and so on. And like I mentioned, sort of working with, different decision makers in the territory. Yet that role of academia to be able to like step outside of all of that and say, 25 years from now, here's what's possible, or, looking at how long some reforms take. But this really broader approach to the health system or systems for health and what that might be. And I think, and so there's some balance there. I think there's some room for some creative work, envisioning in terms of like what the system could be. And, I don't know if we'd ever see major reform in the Canada Health Act, but maybe people are going to become more open to that. But some of the international comparisons, for example, with European jurisdictions, so Norway and Finland, and looking at much more of a health in all policies approach. And I think it was when Finland joined the EU, they're sort of backing up a bit. Their health in all policies approach really kicked in the 70s, when their diabetes rates were going up and heart attacks and so on. And they realized, we need to do something drastic here, and, brought in, agriculture into the conversation. So, selling more 1% milk in the schools, and, bringing in education to do that and so on, and have a number of initiatives that sort of began to bring these rates down, and they came down. And when they joined the EU, there were certain policies that all of a sudden rubbed, and I don't know if I'm giving the correct example, but say the 1% milk, and then in Italy, they're like, what, 1% milk? Like, we're not gonna, but there were certain, so when Finland took the chairmanship of the EU, health and all policies was one of the priority areas that they worked on. And then that sort of trickled up to the World Health Organization office in Copenhagen, and they, which was like for the European region, and developed a lot of this EU 2020 strategy and so on, where they really pushed this health in all sectors. But sometimes I wonder, like, maybe Canada and the US need to join those tables, or we need to have a global table where we can get the decision makers in the room together. And, EU has a totally different push behind it. So I don't know if you really could mimic that, but sort of that, just suggesting international comparisons as one way that we can highlight some of the other jurisdictions that are already doing this multi-sector work.
For sure. And I'll just add, you know, at least they have an articulated strategy. I haven't heard one in Canada, actually, and or even provincially for that matter. So kind of interesting.
Yeah.
Thank you very much.
Yeah, you're welcome.
It's perhaps interesting that one of the wider determinants of health that may be one of the earliest adopted into these frameworks might be around food. And I was wondering if we could ask you, Susan, to speak for a moment about the Northwest Territories context and how closely food, self-determination around food is linked to health and the health system.
Right. Yeah, and I think there's a lot of work, like if we look at like one example would be the caribou decline and the huge impacts that's having on health and the ability to access food in communities. And the Clecho government, they have a research institute based there, and they've been closely monitoring the caribou with community-based monitoring and looking at both sort of, you know, what's causing these declines and then, you know, how to respond to that. So I'm actually part of an interdisciplinary team within the Clecho government. And the overall project is called Ban from Our Land. And the theme that I'm working on within that is health system stewardship. So looking at sort of putting this lens across some of the questions. And then there's others who are looking at the caribou. And we've been sort of working on this a couple of years, but just getting to the point now of, you know, beginning to sort of started with some individual projects and then talking to one another about, you know, how they cross and it's, so I think part of it in looking at it is the process. So it's, you know, the ability to have those partnerships with the Indigenous government and with those who are working, and I say Indigenous government, and I'm talking the NWT context where there are land claims settled and governments have authority and control over those areas. And then they have different intergovernmental agreements and that you're able to sort of shift some of these policy levers and look at, is that a policy that we leave at the territorial level, or do we drop it down and have more self-determination and control? So I don't know if that answered your question. I sort of went on a bit of a tangent.
No, that's really interesting to think of that Clecho project as one in which the health of the caribou and the land is the overarching sort of orientation, and then health system function or performance is viewed within that. I think that would overturn any kind of Southern framing of health system performance and, you know, place it within a locally, culturally determined framework. I think that's really novel and interesting, progressive.
Mm-hmm. Yeah, no, it's interesting for sure. And very refreshing to come into it that, yeah, it's sort of not all the health system, but you're kind of one piece of the whole. And it's being really well coordinated. So yeah, it's been a pleasure to be a part of that.
Right, are there any other questions for Dr. Chatwood before we let her go? We've probably taken enough of your time today, but thank you very much for giving us an hour of your research time. We really appreciate it, Susan, and I'm just pleased to see you again.
Yeah,
personally
nice
too.
to see everybody.
So thank you for coming, and I'll just put a little plug in for next week when our speaker is Jan Doa Vanderploeg of Wageningen University in the Netherlands, whose presentation is Unraveling Heterogeneity and Strengthening Resilience. All right, so thank you very much for coming today.
Okay, thank you.